So now that we finished talking about polycythemias and the various kinds of polycythemias, we're basically moving on into the transfusion reactions, which in step one is a topic talked about within the immunology chapter, right? So that's not really a hematology topic in step one per se, but it's definitely related to hematology. So we're going to need to revisit the step one book to look at all that and have a better understanding of how to truly differentiate each one of these from the other. Right. So here they have it in columns up to down. Says allergic reaction, anaphylactic reaction, febrile, non-hemolytic, or hemolytic. There's more than just these four. So if we come back to step one book, it's a little better here. It's also more updated from first aid 2021 and everything. So we have the allergic anaphylactic acute hemolytic transfusion, febrile non-hemolytic transfusion, and then this transfusion-related acute lung injury and delayed hemolytic transfusion reaction. Right? There's a bunch of these now, much more than used to be there not too long ago. So it's gotten a little more intense. But one of the key ways of differentiating these things is really just based off of the time span. How much time has passed since you started the transfusion and how much time has passed since you actually finished doing the transfusion. So those are two things you want to watch out for in the question. You really want to see what are they telling you in the question. Are they telling you how long it's been since they started, or how long has it been since the transfusion was finished? Now the allergic one is a type 1 hypersensitivity, like allergies in general, right? So allergies and anaphylaxis have nothing to do with really the antibodies per se, right? So it's usually just an issue with antigen, some kind of antigen causing mast cell degranulation, as you can see in this image. If you have forgotten your hypersensitivity types and what they're all about, definitely a good day to go back and revise that anytime you revise blood transfusions. Remember that type 1 only had one thing, an antigen. Type 2 has antigen and antibody. Type 3 has antigen, antibody, and complement. And then type 4 is delayed because that one is T cells, right? It takes a long time to make T cells. So this allergic thing is just the allergen, right? So you're going to have sort of an allergic reaction of urticaria, which is just kind of hives, right? Pruritus, which is itchiness, a wheezing thing, hypotension, possibly respiratory arrest, and shock. The last two being the worst kind of reaction you can get here. Previously here they used to have fever written, so I made sure I fixed that. They published an errata for that, so make sure you don't have fever written here in your book for allergic and anaphylactic. Allergic reaction doesn't have any fever, so this is wrong here too. This is incorrect for the allergic reaction. There should not be a fever, and that's something you want to make sure you get out, because once you take that out, it clearly becomes a lot more different from these two guys, right? This one is called febrile non-hemolytic reaction. It has fever. This one is a hemolytic transfusion reaction that also has fever. So it's really important to make sure you can differentiate those guys from allergic. There's many different things to differentiate them with, but just got to make sure you have that down. The allergic does not have fever. All right, so that's not really going to be one of your key features. Now, mistakes like this are really annoying when it comes to first aid and stuff like that, because then you really don't know what to even believe anymore. Let me also just check real quick the first aid 2021 and what happened there. Because if they have fever written here in first aid 2021 still, then that basically means they ignored their own errata, which would mean that maybe it wasn't an errata. So that would be pretty annoying, right? So you can see here, so in first aid 2021, they kind of restructured the same information. So they have donor blood and host blood, and they're showing you what's causing the reaction. So we can look at it here, but type 1 doesn't have fever, as you can see. Right? Allergies, you're going to have the urticaria and pruritus. And the anaphylactic one, you're going to have wheezing, hypotension, respiratory arrest, and shock. No fever. Right? It's a very important thing to to understand. And actually, I'm going to move this note over into my CK as well, so you guys can have that as your final thing. All right, so let me edit the book too, because this is a pretty silly mistake on their behalf, you know, and clearly they fixed it in first aid step 1, but they haven't fixed it from first aid CK, which again is just them being too busy counting their money, right? So no fever. All right, so let's look at it here. So allergic anaphylactic, they've nicely divided it up now. The allergic one really just has the urticaria, which is hives and itchiness. The anaphylactic one, which is more problematic, has wheezing, hypotension, respiratory arrest, and shock. And it occurs almost within minutes. So this can actually occur while you're still doing the transfusion. Why does it occur? Well, it's a type 1 hypersensitivity reaction against plasma proteins within the transfused blood. Right? So the donor blood has these plasma proteins, including IgA, which the host is going to see and react to, and react with mast cell degranulation, which is what causes this anaphylactic response, right? And if you have an IgA deficient patient, a patient that doesn't make IgA, then you don't want to give them IgA, right? If someone doesn't make IgA and you give them IgA, then their body is obviously going to recognize that as a foreign invader and cause a reaction. So that's pretty bad. Right? Within minutes to 2 to 3 hours max, and the reason it's able to occur so quickly is because it's reacting to preformed inflammatory mediators. Right? You didn't need to make anything. Everything that's reacting is already ready, and it just attacked. It immediately attacked. That's a very key thing to watch out for there. Then you have acute hemolytic transfusion reaction. Right? So this one is a type 2. Right? And there's going to be hemolysis, which you remember we've looked at hemolytic things that can occur. So every time you have hemolysis, you kill your red blood cells. That means hemoglobin is going to be floating around. If hemoglobin is floating around, then haptoglobin is going to be causing problems. Let me just make sure. Right, and then you're going to be seeing all of those things, including jaundice, right, which of course always occurs every time you kill red blood cells. You release heme, the heme gets converted to bilirubin, and then that's all going to cause excess bilirubin production, which leads to presentation of jaundice. So you can see the issue was from the donor blood having these antigens. Basically, the issue is with ABO blood type, right? If you give someone who's a type A blood person and you give them type B blood, they're going to attack the blood and kill it, right? Because they obviously don't recognize the blood. What's happening here? Okay. So anytime you get a patient who's having ABO blood compatibility issues, we're going to look at some practice questions. You'll see that usually the main thing with these usually the main thing is that they did the blood transfusion on the road. So for example, a question will tell you that a patient might have been in a really bad car accident, and then they had paramedics show up to the site where the accident occurred, and they had immediately initiated giving blood, which is a very rare scenario to even really do that, but sometimes patients are at such a bad condition that you have no other option but to give them blood. So in the real world, such scenarios will only really occur if you have O negative blood. You just give them O negative blood. O negative blood doesn't have any antibodies on it, so your body can't react to it, right? That's the blood you can give to anybody. But in these questions, for question purposes, you imagine a world like that doesn't really exist, so you have to be careful and suspect that when you read that in the question. Right? It starts occurring very, very quickly because it doesn't take too long. These antibodies are also usually preformed. So for example, if I have type A blood, then my blood will be full of anti-B immunoglobulins. I'm going to have anti-B antibodies within me, and vice versa. So these antibodies are already ready as well, so it can occur very quickly. Then you have the febrile non-hemolytic transfusion reaction. So this is really nice that they named it this way, because you're going to see these two things. You're going to have fever, which is shared with acute hemolytic transfusion reaction. So you're going to still have fever in both of these guys, but the non-hemolytic one doesn't have any hemolysis. There's no killing red blood cells in that manner. So that means that you should not really see anything in the question regarding hemolysis occurring. So no jaundice, no hemoglobinuria, right? None of that stuff. Cytokines created by the donor white blood cells accumulate during storage of blood products. Reactions can be prevented by leukoreduction of blood products. So the main thing causing the transfusion reaction is the fact that the white blood cells that were sitting in this preformed blood before it was given to me, as a packet that was just sitting in the hospital, it was releasing cytokines. And those cytokines, when they transfused the blood into me, caused fever, headaches, chills, and flushing. So these are all things that can occur because of cytokines, right? Like there might be interleukin-1 in there and other things like that. More common in kids, occurs extremely quickly just because it's just cytokines. You didn't need to make antibodies, right? So these three guys are very different from each other. Very different from each other for obvious reasons. Clear differences are visible, and when we look at practice questions, you're going to see how easy it is to really catch these differences. These three are also pretty easy to work with. Then you have these last two. So this one is transfusion-related acute lung injury, right? A common URL question on this topic always mentions that there has to be this priming that needs to occur, right? So there's a two-hit mechanism. First, neutrophils are sequestered and primed in pulmonary vasculature due to recipient risk factors, right? So this person already has neutrophils that are ready. So once again, because of that, it can occur within minutes. The reaction can actually occur while you're doing the transfusion. Then the second hit, neutrophils are activated by some product in the transfused blood, and that causes a release of inflammatory mediators that increase capillary permeability, leading to pulmonary edema, which can cause lung injury, right? So you're just going to see respiratory distress, and their pulmonary edema is not going to be cardiogenic, which means that they don't have pulmonary edema because their left heart isn't working and blood backed up and everything came out in the lungs. That's not what's happening. Their heart is working perfectly fine. It's just that they have these weird things in the blood that was being transfused, and only the neutrophils in their lungs were primed already to attack it. So it attacked it. It attacked the blood as soon as it got to the patient's lungs. Right, so you have to be careful with these questions to not pick another answer choice like ARDS, acute respiratory distress syndrome. Although this is an acute respiratory distress issue, it's not just ARDS. You're not going to see ground glass opacities or anything like that on chest x-ray. You're having this issue because your patient is actually responding to the transfused blood. Right? So it's a key thing to watch out for. The last one is your delayed hemolytic transfusion reaction. So this one is delayed. This one actually takes time. They call it an anamnestic response to a foreign antigen or donor red blood cells previously encountered by recipient. Typically causes extravascular hemolysis. So you're going to have hemolysis again, which is going to cause the hyperbilirubinemia. Right? Onset is going to take more than 24 hours, usually presents within 1 to 2 weeks due to a slower destruction by reticuloendothelial system. Generally self-limited and clinically silent, so you don't need to worry about it too much. This is probably the easiest one to identify of all of them because of how long it takes, more than 24 hours. The others will all usually occur within 24 hours. Within even 6 hours for the most part, right? So really, really critical stuff to watch out for. Now take a look at these questions I have here. So this one says a 34-year-old man is brought to the hospital, got my pencil, after being in a motor vehicle collision as an unrestrained passenger with considerable trauma, so really bad accident. On arrival, he's hypotensive and bleeding from many sides. The patient receives an emergency blood transfusion. En route to the operating room, he develops difficulty breathing. So this is the scenario I was talking about, right? He's getting an emergency blood transfusion, which means that you didn't have time to give him blood that matched his blood type. And they didn't tell you in the question that they just gave him O negative blood. Like, that's the only time you can give somebody blood without having to match it. Just give them O negative blood. O negative blood doesn't have any antibodies on it, so they're not going to react to it. But in the world of exams, this kind of stuff doesn't happen. So when they tell you there's an emergency blood transfusion happening, they're basically telling you they did a transfusion without matching, right? So en route to the operating room, the patient develops difficulty breathing, chills, and pain in the chest and back. His urine also turns brown. Which of the following is the most likely cause of his new findings? And the answer was complement-mediated cell lysis. This can be fatal and requires immediate cessation of the transfusion. Anti-ABO antibodies, whichever issue he had, and the recipient bind to the corresponding antigens on transfused donor red blood cell and activate complement. Anaphylatoxins cause vasodilation and symptoms of shock, while formation of MAC leads to complement-mediated lysis. Right, and that's exactly how that works. So this is just going to be this case scenario: acute hemolytic transfusion reaction. Right, so you see how one of the key things in this one is that you have hemolysis. So the hemolysis causes the hemoglobin urea, the jaundice, right? They're talking about that. They told you his urine turned brown. That's a very important thing to watch out for. And then of course he has chills because he's got fever. Right? He's already hypotensive, as they told you. They're describing a form of shock in the sense. So it's very important to understand that aspect. Right? It's pretty straightforward, open shut kind of question. NBME loves this topic as well. Step 1 NBME loves transfusion reaction questions. This one here is a 33-year-old woman, G4P4, is admitted to the hospital after she sustained a splenic lacerating motor vehicle collision. 3 units of packed red blood cells are administered. 5 hours later, she develops shortness of breath. Her respiratory rate is 29 and crackles are heard throughout both lung fields. So this is pretty easy, right? They did a blood transfusion and then now you hear something in the lung, crackles in the lungs. A chest x-ray reveals bilateral lung infiltrates. Arterial blood gas analysis on room air shows a PO2 of 55, right, which is really low. Which of the following is the most likely cause of her condition? Transfusion-related acute lung injury. Very straightforward. Right? The patient had a transfusion and within 5 hours developed respiratory distress. Boom. This one here, MU22, 26-year-old woman develops hypotension and hemoglobin urea after receiving 1 unit of packed red blood cells. They didn't give you a time frame, but she's receiving blood and now she has hemoglobin urea, which means there's hemolysis occurring. Right? What is most likely to be involved in her condition? Well, of all the answer choices they had there, it had to be antibody and complement, which is again acute hemolytic transfusion reaction. Right? Because something hemolytic is happening. As you can see here, the hemolysis really only occurs in acute hemolytic transfusion reaction and then in this delayed hemolytic transfusion reaction. So the two hemolytic ones are very different from each other based off of the time span. One occurs very quickly, the other occurs the next day after 24 hours. Right, so the hemolytic ones are very different from each other. Coming back to here, it's all the same information, but again, like the CK first aid is not that good at all, so it's very important to make sure you read alongside or revisit First Aid 2021 for things, the Step 1 First Aid for things, because this isn't that complete at all. And then, I have some practice questions here so we can look at them, because there's actually one other case scenario you need to know about, which is this thing here, transfusion-associated circulatory overload. So this is not a transfusion reaction per se. It's not that you're reacting to the transfusion, but transfusions can do many things, right? One of the common things we already saw blood transfusions can do is cause an iron overload, right? You give too many blood transfusions to anyone, they're going to get an iron overload, and then that's problematic, right? Too much iron in their body, and then you have to give them things like deferoxamine, Ferocerox, or anything like that, which are iron chelating agents. So this question here from Amboss, a 45-year-old woman comes to the emergency department with severe menorrhagia for 3 days. She also reports dizziness and has hypertension. Wait, let me get my pencil. So her presenting issue is severe menorrhagia for 3 days. She's got dizziness, she has hypertension for which she takes lisinopril, so those two things cancel each other out. She appears pale, her temperature is kind of high, that's febrile. Pulse is fast, always underline or always highlight any vitals that are out of the usual. So she's got fever and these symptoms of high pulse and low blood pressure, kind of looking like shock. Pulse oximetry shows an oxygen saturation that's really good, 98%. Pelvic exam shows vaginal wall with dark maroon blood and clots, but no active source of bleeding. So the pelvic exam is showing dark maroon blood and clots, which is probably her menstrual cycle aspect of things. She's 45. Well, yeah, she hasn't hit menopause yet, okay? Then they go on, her hemoglobin concentration is very low. Crystalloid fluids are administered and she is transfused with 4 units of cross-matched packed red blood cells. So they match the blood, so there's not going to be a hemolytic reaction. 2 hours later, she has shortness of breath and dull chest pressure. So 2 hours, very important to highlight the time frame here now, because that's what all transfusion reactions are differentiated based off. and the symptom is shortness of breath and dull chest pressure. So they're really trying to make you think of transfusion-related acute lung injury. But we just did transfusion-related acute lung injury, right? That actually had a presentation very similar to ARDS, with crackles and wheezing and a really low oxygen saturation because your lungs are unable to even work. But her oxygen saturation was pretty good here. They go on, so they then say, after that, now her temperature is still 99.7, pulse is still high, and now the new thing is that her blood pressure is super high. Right, so pulse and temperature haven't changed from what it was initially, but her blood pressure is super high. Pulse oximetry still shows pretty good air. Right, so if it was acute lung injury, her pulse oximetry would start getting altered because oxygen would not be transfusing very well. Cardiac exam shows an S3 gallop. Diffuse crackles are heard over the lower lung fields on auscultation. So they do hear crackles, but only over the lower lung fields, which makes you kind of think it might actually be cardiogenic. An X-ray of the chest shows bilateral hazy opacities. An ECG shows non-normalities. What is the most likely explanation of this patient's symptoms? So the X-ray, even bilateral hazy opacities, is also trying to confuse you into thinking transfusion-related acute lung injury. Right? So as you can see, there were two answer choices. 50% of people chose transfusion-associated circulatory overload, which is actually often just referred to as TACO, while 40% of people chose transfusion-related acute lung injury. The patient's hypoxia, bibasilar crackles, and hazy opacities on chest X-ray suggest pulmonary edema. TACO leads to hypertension, a wide pulse pressure, and volume issues like pulmonary edema, S3 gallop, and JVD. The lung injury alternative would present with hypotension and fever, the wrong answer choice, right? This patient's really high blood pressure was extremely weird because that has nothing to do with transfusion-associated lung injury. And then the S3 gallop, remember what S3 and S4 were about, right? S3 was something you more so saw in heart failure, excess volume. Remember why S3 even occurred. S4 was something that was related to a heart that was not really willing to expand, right? So that was usually a patient who had hypertrophic cardiomyopathy. So this patient has an S3, which is indicating some level of heart failure, which means that after you see this S3 gallop, all the chest X-ray stuff, all the lung auscultation stuff, anything else that's happening in the patient is no longer non-cardiogenic. It is actually cardiogenic, right? All her other things are cardiogenic issues. She has a heart that is unable to sustain all the blood, so it's backing up and showing up in the lungs. So she has cardiogenic pulmonary edema. So this is not acute lung injury due to transfusions, right? Very good question for differentiating the two factors because those are both very commonly going to be tested. If you ever get a question on transfusion-related acute lung injury, TACO will be the other answer choice that's there. So you have to consider the differences very closely. Let's take a look at the questions over here now. This one says, 29-year-old man comes to the emergency department following a motor vehicle collision. The patient is alert and oriented. Trauma evaluation shows an unstable pelvis with a pelvic fracture confirmed on imaging. So he had a motor vehicle collision, and his main thing is this pelvic fracture, which really sucks, right? Unstable pelvis. He's a young guy. He receives multiple boluses of IV fluids and is started on packed red blood cell transfusion, which they're not telling me right now if they matched. But since they're already at the hospital, I'm going to give them a bit of a benefit of the doubt that they matched it. A few minutes after the transfusion starts, he develops shortness of breath and has an episode of non-bloody emesis. So they just started. A few minutes into starting, he's already responding in this weird transfusion-related reaction. No chest or back pain. Temperature is fine. See, no fever. So that's pretty critical. I don't need to highlight it, but it's good to see that temperature is fine. Blood pressure is very low. Pulse is very high, so that's basically shock, right? Hypovolemic shock most likely because he's got this emesis, he's vomiting, right? Pulse oximetry is 86%, which is on the lower end, right on a non-rebreather mask. He answers questions in short phrases because he's kind of not feeling comfortable. Lung exam shows decreased breath sounds bilaterally. Pulses are weak. Urinalysis is fine. So again, urinalysis is normal. This is pretty critical right here. Right? Urinalysis is normal means there's no hemoglobinuria, which means he doesn't have hemolysis. So since there's no fever and there's no hemolysis, the only reaction that he could be having so quickly is the allergic one. Right? What is the most likely cause of his respiratory distress? Anaphylactic reaction. You just pick that as an answer choice and you're done. The other people chose another answer choice. 20% of people chose reaction from cytokines in the transfused blood. Now, we saw that one too. We just saw the cytokine one, this one. But this one is special because it's got fever. Remember what cytokines do? Cytokines are like interleukin-1, which literally causes fever. Right, so that was the only real way to not pick this answer choice, actually. Right? So you wouldn't pick this one because this has fever, whereas the anaphylactic and allergic do not have fever. So you see how in that question right there, first aid's mistake of fever really just messes people up. Right, so they finally fixed it in First Aid 2021 here, but in First Aid CK, which is what we're studying right now, First Aid CK doesn't have that fixed. So you want to make sure you get that note into your mind and have that memorized perfectly, because otherwise you would not be able to pick the correct answer for that question. That's a pretty easy question. They explain it pretty well. They tell you of the IgA deficiency aspect as well. Very important to match blood and also make sure that the patient makes IgA. Right? So you want to make sure you give patients the same type of blood they make. And on top of that, you want to make sure you give them no IgA if they don't make IgA. Right? There are people who are IgA deficient. You don't want to give them IgA. These here are tables based off of two different things. This one is showing you the transfusion reactions associated with hypotension. All the ones that have hypotension to it. And remember here, we're going to see the transfusion-related acute lung injury, that's one of them, has hypotension. The first question we just did in this book right here, right, this patient, it was not transfusion-associated lung injury because this patient has hypertension. So very critical difference there, right? Anaphylactic one also has hypotension, acute hemolysis, and bacterial sepsis. When hemolysis and sepsis generally both themselves cause hypotension. Yeah, you lose blood or you have a septic reaction of shock, right? Shock is always hypotensive. And then this one here is transfusions based off a timeline where we know that the anaphylactic occurs the quickest, acute hemolytic occurs pretty much equally as quick. So these timelines are showing you, I don't really like the table very much myself because anaphylactic would take up to this long, right? But acute hemolytic can also occur in this time frame, which means it could occur here or here. It can occur within seconds to minutes, or it could take an hour, right? And then the febrile non-hemolytic one can also occur just like this, which means it can occur pretty quickly as well. But delayed hemolytic will always occur after 24 hours, which means you don't pull a line like that. It's just right here. This is how long it takes for the delayed one. Right? It starts from after 24 hours. So the way this table is drawn, isn't exactly perfect, but it gets the general message across, right? So that's all this really does for you. It's not the best table you world ever made, but you get what they're trying to do for you. Here, 55-year-old man is hospitalized after a massive hemorrhage from a duodenal ulcer. So this guy has internal bleeding, okay? The bleeding is stopped with endoscopic manipulation. He receives 2 liters of IV fluids followed by 2 units of packed red blood cells. He got red blood cells. 2 hours after the transfusion is started, so 2 hours after the transfusion is started, so it's still happening, he starts developing chills and malaise. And then boom, he has fever, which is indicative from the chills he's getting. His blood pressure is fine, right? Pulse is on the higher end, right? So I'll highlight it. Transfusion is stopped and the patient is given acetaminophen. Direct antiglobulin and plasma-free hemoglobin level tests are negative. So there's no antibodies, basically. Urinalysis is within normal limits. The symptoms resolve within 6 hours of transfusion discontinuation. What is the best procedure to prevent this type of transfusion reaction? Before you can even pick what's going to prevent it, you have to realize what's causing it. So they did a check to see if there was any antibodies, and there were no antibodies, which means you could rule out this answer choice. Right? It's not going to be acute hemolytic transfusion reaction because, first of all, this would actually have hypotension, and our patient doesn't have hypotension. Right? Our patient's blood pressure was pretty normal. And second of all, this would have antibodies in it, but they said there's no antibodies. And so this question, they literally did a direct antiglobulin and plasma-free hemoglobin level test, and they didn't really see anything. Antiglobulin, antibodies, nothing. So they basically did a direct Coombs test. That's what they're being tricky by not calling it Coombs test. This is the Coombs test. They did the Coombs test, and it was negative. So if the reaction occurred, blood pressure's fine, there's fever, but there's no antibodies, then the only thing causing the fever was just cytokines. And how do you prevent transfusion reactions from the cytokine guy? which is this case scenario, febrile non-hemolytic transfusion reaction, you can leukoreduce, do a leukoreduction of the blood products before giving it to patients. This is typically done on a standard basis, but in the U world, in the step 1 world, you have to assume maybe it wasn't done and then pick that answer choice. And that's one of the problems with step 1 questions. Oftentimes you read a question and then you're like, well, I'm sure they checked this and that and blah, 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 but they actually didn't check, right? They didn't check. So that's something you want to watch out for. In this question, you can't just assume that they must have done leukoreduction of the red blood cells before doing the transfusion. Even though it's standard procedure, when a patient comes in and you need to give them a blood transfusion, you match it to their blood type. You make sure it doesn't contain IgA, if possible. And then you also leukoreduce the blood product so it doesn't cause this cytokine-induced transfusion reaction. But in the step world and in the world of questions, you can't assume these things. So if a patient shows up with certain symptoms, then you have to understand that was probably what caused the issue. All right, that's probably what caused the issue. Next question here. 3-year-old girl is brought to the emergency department for sudden onset of weakness. She was well until this morning. So this is a young girl, so I'm going to highlight the age, right? Because it's one of the extremes, extremely young. 3-year-old girl, sudden onset of weakness. Very rare to see that. She was well until this morning when she woke up and was unable to climb out of bed. All right. Her mom lifted her up, but the child was unable to bear weight on her right leg. So something's wrong with the right leg for bearing weight. She could not grasp her mom's hand to stand up. She has had no recent fevers or upper respiratory symptoms. She was adopted from Nigeria 6 months ago, and family history is unknown. So I'm going to highlight that too, because adoptions mean that anything is possible, and they're actually picking a country that is pretty much, in a area in Africa basically where sickle cell and stuff like that is much more common, right? So this country is also a giveaway for what could be wrong with the 3-year-old girl that they adopted. No hospitalizations or illnesses since being adopted. Developmental milestones have been fine. Temperature slightly high. That's 99F. Pulse is high. She's awake and alert but difficulty articulating. Head is normal cephalic and atraumatic. Pupils are fine, reacting and doing accommodation. Tympanic membranes are fine. Right? This is the thing STEP loves to do. Giving you mass shit in a question for no reason. Right? I mean, of course, each of these statements tell you something, but it's really just a list of things that are not exactly guiding you to the answer. They're not guiding you to the answer. Oftentimes, these are all these things that they're telling you just to wear your brain out. So you have to be careful not to get burnt out reading these sentences that sound like little lists. Be very careful with that. They go on, cardiovascular exam. Right now here they see something, a bit of tachycardia, but everything's fine. Normal S1, normal S2, no murmurs. She has tachycardia, of course, she's not feeling well. Lungs are clear on auscultation also. So basically everything here was fine. Right? Everything from literally here to here was all fine. Like you literally didn't need all of this shit. You didn't need it, but they put it there because why not? You didn't need all of that. If they took all of that out, it would be such an easier read in general. But again, why would I want to give you a question with an easy read? Right? So you didn't need any of that. There is significant weakness, hypotonia, and hyperreflexia of the right arm and leg. Neuroimaging studies are pending, which is actually the thing we needed. They gave us all this garbage, but the one thing we need for this patient, they're not providing yet. What additional test is most likely to reveal an underlying abnormality? Hemoglobin electrophoresis. In fact, this is probably something you would order for a family who has no history of this girl they adopted from Nigeria. You need to get this established. Does she have sickle trait? I remember we've been doing this in hematology this whole time. If a person comes from a country where, or any region where sickle cell or thalassemia are possibilities, you need to establish if they carry the trait, because you have to advise them to not marry someone else who might also be carrying the trait. That's a very key thing here. This patient presents with acute focal neurologic deficits, which should raise concern for stroke. Clinical features of stroke typically include focal weakness, hemiparesis, aphasia, seizures, or altered mental status. Although stroke is more common in older adults, it can occur in kids, and the most common cause of pediatric stroke is actually sickle cell disease. Right, this patient's history of adoption from Nigeria, a country with a high prevalence of sickle cell, raises the likelihood. Chronic vaso-occlusion can result in endothelial damage, intimal proliferation, and eventual vascular stenosis, which increases the risk of cerebral ischemia, resulting in stroke. So it's pretty evident she's having or had a stroke overnight, right? It's pretty evident from her completely unforeseen, unexpected symptoms of having sudden onset of weakness. A 3-year-old having sudden onset of weakness without much of any infection or any kind of history of something that might have gone wrong, it just doesn't make sense. So it had to be that she had a stroke, and her stroke was due to unmanaged sickle cell. All right. If concern for stroke exists, an MRI should be performed to confirm. Well, neuroimaging was pending. And there was a reason it was pending. There was a reason they gave you everything but that, because they didn't really want to spell out stroke for you, but you had to figure that out from the basics that were given in the question. It's a pretty good question related to sickle cell that we've been looking at. And here are the common etiologies of pediatric stroke. So sickle cell being probably one of the most common ones, right? And then you have a lot of these you won't really see. Prothrombotic disorders obviously can cause a stroke in anyone. Congenital cardiac disease, bacterial meningitis, vasculitis. Vasculitis would be another common one that you'll see in STEP. Focal cerebral arteriopathy is very rare in pediatric patients, but again, this is something you would have to think of. And then, of course, head and neck trauma. Yep, pressure can be elevated in the head, leading to a stroke. So key things right there just to keep in mind anytime you get a question about what looks like might have been a pediatric stroke case. Next question here. This was a great one about AV shunting that a lot of students don't really tend to have really good understanding of. So this is a topic of Osler-Weber-Rindu syndrome, which isn't really talked about in first ACK that well. 27-year-old man comes to the emergency department with unremitting nosebleed, right? So epistaxis, that's all he has. A young man with nosebleed should immediately make you think of Osler-Weber-Rindu. This is hereditary hemorrhagic telangiectasia. So when you're reading this question, you see the nosebleeds, the next thing you're looking for in this question is that they're going to mention any kind of telangiectasias, because then that's a giveaway for the question. He had a similar bleeding episode 1 year ago that was stopped in the emergency department. He works as a computer programmer and has a sedentary lifestyle. He drinks occasionally, doesn't smoke or use drugs. And then here we have it. They did the physical exam. There are several ruby-colored papules, which are telangiectasias, on his lips that actually blanch partially with pressure. Digital clubbing is also present. His abdomen is soft and non-tender. The liver span is 8 centimeters and the spleen is not palpable. All right, so there's no splenomegaly. Labs give you hematocrit 60%, platelets are fine, leukocytes are fine, so pretty much everything's okay. What is most likely responsible for his increased hematocrit? So why does he have this high hematocrit? Well, he must have AV shunting, right? This is not a patient with polycythemia vera. There's no way you could pick that. Why would you pick that? It didn't make sense to me in this question at all. Why people chose polycythemia vera. I get that this is a guy with a high hematocrit with no splenomegaly. It fits the two things that we look for PCV, polycythemia vera. But polycythemia vera is not a person who would have unremitting nosebleeds and a history of nosebleeds. It's not a thing you look for there, right? These weird blanchable things on his lips. It's just not, it makes no sense to think that. It made no sense to think that. So that was kind of odd to me. Yeah, it's talked about, see, so even First Aid 2021 has it, but of course First Aid doesn't really have an image for it. So let's go to my First Aid. So I put this picture right there to show you what they're talking about, right? So these are the blanchable with pressure things they're talking about. Right, so also known as Osler-Weber-Rindu syndrome, which is HHT. Autosomal dominant disorder of blood vessels. You see blanching lesions, which are the telangiectasias on the lips. It can also be on their skin. Recurrent epistaxis, skin discolorations, and AV malformations, which is what we were looking for. GI bleeding and hematuria. Very important. Usually a young guy. Even this question right here, you can see the 23-year-old man who has recurrent nosebleeds. Spider-like angiomas on his oral and nasal mucosa. It's usually a pretty giveaway type of a question. So to pick polycythemia vera didn't really make sense at all. Right, this patient most likely has hereditary hemorrhagic telangiectasias and autosomal dominant disorder with diffuse telangiectasias, recurrent epistaxis, and widespread AV malformations. AV malformations in the lung can shunt blood from the right to the left side of the heart, causing chronic hypoxemia, digital clubbing, and a reactive polycythemia. Pulmonary AV malformations can also present as massive sometimes fatal hemoptysis. PCV, polycythemia vera, is a myeloproliferative disorder that typically causes increased production of all three bloodlines, and you would see splenomegaly, right? But this patient didn't have it. Telangiectasias and digital clubbing are not present. In fact, they're able to do their oxygen exchange really well because they have all these extra red blood cells, right? So clubbing is one of the things you see in patients who are hypoxemic. You wouldn't see clubbing in a patient who has polycythemia vera, where they have so much red blood cell to carry oxygen. They're not going to be hypoxic, right? So that's kind of surprising for this question, but I also get it because AV shunting is something very few people truly understand. Like, that's a respiratory topic, right? It's not the AV shunting that you think of when you go to cardiovascular. This is an AV shunting that's a respiratory topic, where they tried explaining it here. So they said that AV malformations in the lung can actually shunt blood from the right to the left side of the heart, right? That's what an AV malformation in the lung does. So it literally takes blood from the right heart and then brings it to the left heart. That's deoxygenated blood in your left heart now. Right, so that's the right to left shunt that you get with an AV shunt in the lung. So the respiratory AV shunts are a whole different thing. And this right to left shunt is different from when we talk about the heart, and there's left and right shunts in the heart itself. That's different. So just be careful when you get these questions, because Steph loves this topic, talking about shunts and mentioning right to left shunt as an answer choice in respiratory. But when I did respiratory, in my respiratory videos, I've broken down this thing very well for you guys, because this is literally a topic very few people tend to truly understand. But if you get to, like, right here, you can see they have it, right to left shunt. Right to left shunt. So when people see this right to left shunt, very few people truly understand what that means in terms of respiratory. We all know what a right to left or a left to right shunt is in the heart, and we have the vape later mnemonic for VSD, ASD, PDA, isolander. Those are the vape left to right, so later. And then the right to left ones were the 1, 2, 3, 4, 5 things, right? So those are all your cardiac shunts. This is a respiratory shunt that causes the right to left shunt, taking blood from the right heart to the left heart. So that's all deoxygenated blood, right? That causes an increase in the AA gradient. And of course, we've talked about this many times in the past. I mean, not me and you guys, but I've talked about it many times in my videos. So, when you do the respiratory videos, which you guys have access to, then you will definitely see that more, right? You're going to see that a lot more. So that's what's happening when you have an AV shunt in the lung, okay? This question is also relevant to what we've been doing so far. So this is going to be about warfarin, heparin, and stuff like that. And people were pretty lost in this question. Very intense question where only 20% of people got it right. 60-year-old man comes to the emergency department due to 2 days of right calf pain, swelling, and difficulty bearing weight on his right leg. So at this moment, it sounds like a DVT. Right? When you have calf pain and it's not due to trauma, that's a DVT or suspicion of DVT. He has no chest pain, shortness of breath, lightheadedness, or syncope. 4 weeks ago, he was treated with antibiotics and underwent left hemicolectomy for recurrent diverticulitis. So he has recurrent diverticulitis, he got a hemicolectomy, okay. Might be relevant. He had an unremarkable postoperative course and was discharged from the hospital 2 weeks ago. Oh, I get it. So he was actually hospitalized for a super long time, which means that he was immobile for a very long time, which is a risk factor for DVT. His other medical conditions include diabetes, hypertension, and end-stage renal disease on hemodialysis, all of which really isn't making the case scenario any better for him. He does not use tobacco, alcohol, or drugs. He has no family history of heart disease, sudden cardiac death, or blood clots. Vitals are pretty normal. Right calf has moderate ankle edema and is larger than the left calf. Calf. Okay, period. Then pain with dorsiflexion of the foot. I think I might have forgotten to put in a sentence or two here, but there's calf pain with dorsiflexion of the foot, which is probably talking about the same foot where he has this right calf pain, okay? And that's actually a type of sign you have to watch out for, so I'm probably going to talk about that here in the explanation. But I think it was just supposed to say that the right calf has moderate ankle edema and is larger than the left calf. And then there's pain with dorsiflexion of the right foot. Duplex ultrasonography shows a non-compressible right femoral vein what is the most appropriate next step in his management. So generally speaking, if someone has this issue, what can you do? So one answer choice was do an unfractionated heparin and then give warfarin. And I don't know how everyone didn't jump on that answer choice. That was the perfect answer choice. Literally, you want to do a heparin bridge and then put the person on warfarin, because if you just put somebody on warfarin out of nowhere, that can lead to tissue necrosis. So you do the heparin bridge and then you put them on warfarin. I thought that was the perfect answer choice. Then people started thinking too much, I'm assuming, and chose all these other answer choices. So a good 20% of people chose low molecular weight heparin only. Another one chose low molecular weight heparin followed by warfarin. So that's also another 20%. And then 10% each chose IVC filter placement or heparin only. So I can see how looking at all these answer choices together at the same time without really having full mastery or a good mastery of this topic can confuse you. But unfractionated heparin followed by warfarin, how could you possibly go wrong with that? That was like the perfect, safest answer choice to go. For a 60-year-old patient like this, there's no reason for you to have to worry about using low molecular weight heparin or so look at all the other answer choices. Actually, it's really interesting. These two answer choices both use LMWH, and then this answer choice is only heparin. So it makes no sense to do either one of those three things, really. Why would you do that? What is it that really would make you wonder to use LMWH and not just use normal heparin and then go to warfarin? The only critical things he had that could make you consider what medications to put him on are the fact that he has renal disease. Because remember, your liver and your kidneys are significant when it comes to getting rid of medications you might be taking. But he doesn't have any liver disease. He does have renal disease, which is a problem for actually getting rid of medication metabolites in the urine. Okay, sure. So looking at the explanation, this patient has a provoked DVT due to recent surgery. Treatment with anticoagulation can prevent extension of the thrombus, acute pulmonary embolism, and possible development of future thrombus. Provoked DVT due to recent surgery will likely last at least 3 months of treatment. Warfarin is the preferred long-term oral anticoagulant in end-stage renal disease patients. Very critical thing to remember. You can give warfarin to pretty much any renal patient. It's not going to be a problem. It inhibits the synthesis of vitamin K-dependent clotting factors 2, 7, 9, 10, as well as the anticoagulants C and S. Warfarin takes several days to become therapeutic and actually first acts on proteins C and S, which are anticoagulants. So you get rid of your anticoagulants while you still have some coagulants, which can cause a transient prothrombotic state that can lead to tissue necrosis. So that's pretty problematic. As a result, it generally cannot be started alone. Warfarin takes several days to become therapeutic. Cannot be started alone. And then I wrote the same sentence again by mistake. And then right here, this patient therefore will need to be started on IV unfractionated heparin for immediate treatment of the DVT as it acts quickly. And then on warfarin as a heparin bridge kind of thing, typically in the evening in the same day. Heparin is continued for 4 to 5 days until the INR is at therapeutic levels between 2 to 3. LMWH, the other answer choice that people were picking, is not recommended in end-stage renal disease. Whether or not you would know that is not really the most significant part. Giving someone unfractionated heparin and then adding warfarin after that, after doing the heparin bridge, is literally the safest answer choice. I mean, if you've studied hematology and you've looked at Heme Pharm from even step 1, then you would know that and you'd be okay. So it was really interesting to me that who are the people that are doing these questions that are literally so far confused with all these answer choices. Right? Because if you haven't finished step 1 and you're doing CK questions, then I guess it can make sense. Right? But after doing step 1, if you're doing CK questions, well, after step 1, you know this already. So it's really interesting to see the level of confusion here. Right? So LMWH is not recommended in end-stage renal disease. Warfarin is actually preferred in end-stage renal disease. And unfractionated heparin is the better one to pick. LMWH is bad in end-stage renal disease because it's actually metabolized by the kidney. So their use in patients with end-stage renal disease is actually associated with increased bleeding risk because they're essentially going to overdose. Right? IV unfractionated heparin is not contraindicated in end-stage renal disease. Great. What else happened here? The IVC filter. That is something you actually use sometimes. But IVC filters can only be used in patients in whom anticoagulation is contraindicated. If the medications are contraindicated or don't even happen to work for whatever reason, then you could think of doing an IVC filter replacement, which is clearly invasive and surgical, and you want to avoid that as much as you can, right? Unfractionated heparin alone, the last answer choice, would generally not be great because it's an IV medication and needs to be continued until the INR is therapeutic, which can take several days. Right? You can't take heparin at home. Another key thing to keep in mind. Right? This is why warfarin is so important. You can eat warfarin at home by yourself and just keep coming back to make sure INR is within therapeutic range. So this was a great question to tie in a lot of key factors that people often tend to not really know. Now this thing here, the pain with dorsiflexion of the foot, is actually a type of thing you can do within the clinic that proves that there's a DVT. So whatever leg has pain with dorsiflexion, so if this was my leg and this is my foot, if I do this, if I do dorsiflexion towards myself, make my big toe point towards my face, then and I get pain, then that's how you know that it's not entirely specific to a DVT, but it is something that occurs in a DVT. So if you already think a patient has DVT and then you do this and it works, it hurts, then you further strengthen your suspicion that it probably is the patient with DVT. That's a really, really good question right there. Last one here, 32-year-old Italian man. It's always interesting when they mention someone from a specific country or region that's out of nowhere, right? So Italian, so European. Comes to the office for a routine checkup and lab results. Okay, so now here's another thing. Keep in mind, if they ever say someone's coming in for a routine checkup, coming in because they have a job evaluation, coming in because they just haven't seen a doctor in a long time, whatever it might be. If it's because they're coming just because they wanted to come and there's nothing that's forcing them to come, then you want to start thinking of answer choices that are probably not going to require treatment. And it just so happens this is also one of those questions. Look, the answer was reassurance with no specific therapy required. This is almost always the fact. It's almost always the fact, right? If you ever have a question where a patient just came in because they felt like they should, just for the fun of it, whatever, I haven't seen a doctor in a long time, let me go see a doctor. Okay, or they came in because they're starting a new job soon and the job is making them come in. Those are all scenarios like that. You want to make sure you start thinking. The patient didn't come because he's dying. The patient didn't come because of any specific symptoms that are hurting them. So everything's okay, right? So and sometimes there will be something that's wrong, but more than often this is the case. So this person comes in, routine checkup, and lab results show hemoglobin 10.8, red blood cells 5.7 million, a very low MCV, 61, leukocytes 55K, that's also pretty low, platelets 170K. Peripheral smear is given to the left. Right, well, leukocytes, actually that might be, we can ignore that, it's not the worst kind of thing. Leukocytes 55K, 5,500? No, 55,000, right, 55, yeah. We could probably ignore that, maybe not, but either way, we'll keep it on the radar. Platelets are normal. Peripheral smear is given to the left, so this is the smear they gave, okay. So looking at it, we see some red blood cells that look like this, which is literally a balloon. But then there are some that look like this, which looks weird because this is not what you expect, right? This one here looks more like a target. You're supposed to have central paleness, central pallor. Like the most ideal looking red blood cell is like this guy here. Right? This guy looks pretty good. This guy looks good. This guy here is a target. This guy here is spherical. So it's pretty safe to say that whatever's happening to this guy, it would have a pretty high red blood cell distribution width, right? The RDW thing we talked about. Remember, RDW was red blood cell distribution width, which is basically a case scenario where all your red blood cells have different sizes. And we can see that here, right? Some of these are going to be thin and small. This S guy is pretty big, different shapes. So microcytic anemia with an elevated RDW, as we can see from the slide, is probably just iron deficiency anemia. So they ask you, what is the best treatment plan for this patient? And the correct answer was reassurance with no specific therapy required. Why? Well, for one thing, he didn't come in saying that he feels anemic. He's not here saying he's got fatigue, he's getting tired. he's feeling cold, none of that stuff, right? He's not really feeling that. And then on the other side of things, he's not really here because he wants treatment, right? If a patient comes in and really wants treatment for something that they feel is problematic, then you can think about it. Now, revisiting this slide, though, the rest of the red blood cells, for the most part, the biggest issue in this image is that these red blood cells all look very different from each other. Like IDA, iron deficiency anemia, isn't really known for all the red blood cells to look this different from each other. And seeing a target cell is pretty interesting, right? Because IDA doesn't have target cells, and it's not just one. And in fact, even this one, here's another target cell, here's another target cell. We're seeing a couple. Right? Target cells are a major deal from step 1, where they showed you and taught you what target cells were. So because I see these target cells, and because most of these red blood cells pretty much tend to have the same radius, right? Like the RDW, although it could be slightly elevated from what I see here, keep in mind this is a peripheral smear. When you prepare these slides, things get messed up. For the most part, though, they all do look like they can stack on top of each other. I mean, look at this guy. This guy's pretty big. He's big, right? This one's a really fat one. This one's kind of stretched out and big. This one in the back here is clearly bigger than the one in front of it. So the RDW is one thing, sure, but the target cell is a huge giveaway that in conjunction with the fact this guy is Italian, I'm more so going to be thinking this is probably some thalassemia. Right? Thalassemia has had this thing where some occur in the European area, some occur with the Chinese individuals having the cyst type, right, all of that. So moving on, they tell you microcytic anemia is most often due to IDA or thalassemia minor, which for him it would be minor because this guy has no symptoms. Although both can cause hypochromia and target cells, significant microcytosis in the setting of mild anemia and normal rather than low erythrocyte count suggests thalassemia. Patients of Mediterranean descent are most likely to have beta thalassemia, while patients of Southeast Asia are more likely to have alpha thalassemia. Confirmed with electrophoresis, patients with thalassemia minor do not show improvement with any iron supplementation, so no treatment is actually required. Right? Iron deficiency anemia would not have microcytosis until hemoglobin is less than 10. This guy's hemoglobin is 10.8. So again, like this was a very straightforward question with minimal information because they didn't need to give you too much information once they gave you a slide. And the slide had target cells. Right? So you can see from this table here many of the ways to differentiate IDA from alpha from beta thalassemia. Right? And you can see treatment, response to iron, has no improvement in the thalassemias. It's really just the answer to iron deficiency anemia. That's the only time giving iron will actually mean anything. Right? So you don't do that for patients who are just anemic. And you never do much for a patient who has no symptoms. That's the most important thing I want you guys to take away from that question. Right? And here, immunologic blood transfusion reaction. So we talked about these guys. Right? We see how there's a lot of blood transfusion reaction things that can occur. All right, there's also a graft versus host transfusion reaction, by the way, which they've got in UWorld. Right? Usually when we talk about graft versus host, we talk about organ transplants. But here they're talking about a graft versus host transfusion reaction, which again is heavily differentiated based off of time because it takes within weeks. It takes a long time. Right? Delayed hemolytic was the one that took the longest so far, after 24 hours. Right? The rest of these occurred pretty quickly. And they had some that had fever, some that didn't, some that had only cytokines, no antibodies, and so on and so on. So this graft versus host one takes within weeks, and it occurs because the donor gave you T lymphocytes. Same thing that occurs in graft versus host with organs. This is graft versus host with transfusions. And you get the rash again, which is the main thing. You know, to me, the rash is the giveaway. You get this rash, and you immediately know what the problem is. And of course, compared to other transfusion reactions, these patients also end up having pancytopenia because the transplanted marrow that's making the blood isn't that functional. It's not going to work. All right. And we talked about this already. So that wraps up your transfusion reactions, which was one of the big deals with red blood cell disorders. And then next time we meet up, we'll be able to dive into white blood cell disorders as well as plasma disorders and really wrap all of that up because that's a lot of pathology that we've kind of already been looking at in step 1. And I want to spend a lot of time making sure we do these questions. So we're going to have a pretty good lengthy session on Wednesday because I'm actually pretty prepared to get rid of all of this white blood cell disorder in one day, in one video. So make sure you guys join Wednesday. I'll probably start maybe like 5:20 p.m. just to wait for people to join. But be here. I'll be here by 5. I'll have the session started up already so you can just join in and wait. All right, so thanks a lot for coming through, guys, and I'll see you guys again on Wednesday.